What's up guys, and welcome back to my YouTube channel. My name is Omar, aka Daher Radiology, and today we're going to be doing something special. A little bit of interpretive skills. We're going to be interpreting a chest x-ray and how I go through the process. So let's get started. Alright guys, so today we have a normal chest radiograph that I want to go through how I interpret a chest radiograph. We're not going to go into super details about the entire approach because there are multiple approaches out there that you can read about on your own time. I'm kind of going to go through how I approach a chest radiograph and the things I do to make sure I don't miss, those hidden corners or those missing areas. So why don't we get started? Obviously the first thing you do in any radiograph, you want to make sure that it's adequate, and in doing so you're checking off the list of things. As you probably already know, you want to make sure that there's good penetration so that you can see all the structures appropriately. Make sure you can see the vertebral bodies through the spine. You want to make sure that the patient's not fully rotated. So if you look at the clavicles, you want to make sure they're equal distance from the actual spinous process to the other side, and this patient's not rotated at all. So that's a good position to be. And then as well, you want to make sure that it's adequate in the sense that it gets the entire field of view. So all of the lungs are within the field of view, and so those are all good things. The film is adequate in this case. So let's move on to the interpretation of the film. I tend to look on the outside first because those are the places that you're going to miss. And truth be told, if there's a large honking mass in the middle of the lungs, you're going to stare at it and you're going to probably forget about everything else. It's called satisfaction of search. So I tend to look on the outside almost always first. I like to look at the bones, make sure there's no large fractures. So looking at the clavicle, looking at the head of the humerus, if you can see it, you can see the actual shoulder joint in general, to see if you can see the scapula and if there's any large fractures within them on either side. And then you want to look at the coming inwards, the soft tissues of the upper arms and extremities, and as well as the chest, to make sure there's no air and lucent air that you would see in emphysematous changes, for example. And then you want to move inwards to the actual ribs. So the ribs themselves, you can see them well on this radiograph, and you can take a look to see if there's any fractures. So you want to follow and trace the ribs down this way, and then also look to the posterior aspects of them. Make sure that there's no obvious fracture, and there's no malalignment or missing ribs, and something that might give you a hint to what's going on. Sometimes you'll see destructive processes within the ribs as well. And then the fractures, you might want to start paying closer attention to pneumothorax or hemothorax, and in the event of a trauma, etc. So that's kind of what I look at next. With the ribs, I kind of come down and I look at the costovertebral angles to make sure that they're clear. And this basically is looking for fluid, and it's most sensitive to look at the costovertebral angles on this view, and to make sure that the sharp delineated borders of the diaphragm are there, that there's no direct elevation of the hemidiaphragms on any particular side for whatever reason. And then I like to go to the mediastinum. So the mediastinal borders are super important. You want to make sure that you trace them all the way down, and essentially the mediastinal borders here can tell you a lot about what's going on and things that are hidden in between. So when you're looking at the mediastinum, you want to make sure that it's not widened. and that could signify that there's lymphadenopathy, that there's dissection, that there's a whole bunch of pathologies associated with that. You want to look at the aortic notch to make sure that it's a normal-sided aortic arch. Sometimes when the aortic arch is on this side, then you can tell that there's potentially some congenital pathology going on. You can follow down the thoracic aorta. You want to look at the AP window. You want to look at the left heart border. A lot of the times you can tell if something's abnormal when these actual outlines are abnormal. The right heart border is nice and clear. If there's a consolidation that's abutting this and obliterating the left heart border, it'll tell you where within the lung it might actually be located, and especially with the diaphragms as well, that'll give you a hint to where the consolidation might be located. So making sure that those borders are nice and sharp. Paratracheal lines, again, lymphadenopathy, etc., to make sure that those are nice and clear. I then look at the airway. So the airway is the trachea to the carina into the mainstem bronchi on both sides. In kids, you can see if there's anything obstructing this airway that they swallowed, and usually goes to the right side because it's more vertical, more narrow, etc. So that's something to look for. Make sure that there's no deviation of the trachea in cases of tension that's pulling onto the trachea for whatever pressure difference reasons. Make sure that it's nice and midline, that it's nice and clear. So that's the airway. We did the mediastinum, and then we looked at the costal-vertebral angles, and then we looked at the diaphragms. So next you want to look at the lung parenchyma, the bread and butter of the chest radiograph. You want to make sure there's no large consolidations, any nodules, large masses, making sure that there's no pleural fluid. You want to look at the hilum on each side. This is where the vessels are coming out of, and very good place to look for pathology, making sure that they're within normal limits for the patient's age, making sure you look at the actual bronchovasculature, and if it's enlarged or absent in certain cases. So in this case, everything looks very normal, very unremarkable examination. The last part I want to talk about are the hidden places. So a lot of the times people forget in general that you need to look at the apices, because there could be a pneumothorax that's hiding out here, or a mass that's hiding behind one of the ribs and the clavicle as well. So making sure you look very closely at the apices, kind of like how I have it here. It's nice and zoomed in. And then you want to look as well very much at the retrocardiac area. And in this location, the cardiac, or the heart itself can obscure any type of mass or consolidation that's hiding behind it. Of course, when you look at the lateral radiograph, this will help to see if there's something hiding out behind. But if you're just given a frontal, on the one view radiograph, you might have something hidden back here that you wouldn't know about. So then you also have the areas that are kind of behind the mediastinum as well, making sure you look at the spine as well. It's it's intuitive, but you want to make sure you look at the vertebral bodies and make sure they're the right appropriate height and length. And then of course you want to see if there's anything that's super striking within the upper abdomen. Sometimes you can see large gallstones or a really prominent gastric bubble that may be causing a hernia or something of the sort. And these are just small things that might be explaining the patient's symptoms that could really help out the team. So all in all, that's the quick interpretation of the chest x-ray. I know it's very brief. It's just kind of how I look at things. If this is helpful, please leave a comment and like and subscribe to the channel. I think that we can do more of these types of interpretation films in the future if this is something that you guys like. And we can do them more with pathologies, because we haven't talked about ICU type films where you're looking at all the lines and tubes that might be in a chest x-ray that are hard to identify, but it's something that it takes practice getting used to, as well as cardiac pathology and surgery that's involved with the chest. You need to be able to recognize them and have an approach to reporting. So guys, that's it for today. Thanks again for watching. Follow me on Instagram at Daher Radiology. We have great round cases there that you can participate in. And as always, like and subscribe to the channel. See you in the next one.